All right, welcome everyone. My name is Shirley, and I will be your moderator this evening. I'm so excited to welcome Dr. Stephen Line and Louis Duran as our speakers this evening. Dr. Stephen Line is a board-certified family medicine and primary care sports medicine physician with a focus on concussion management, ultrasound guided injections, athlete care, and medical education, holding academic roles at Texas A&M University and serving as a team physician for Texas A&M Athletics and local high schools in Brazos County, Texas. And Louis Duran is the head football athletic trainer at Texas A&M. He's responsible for injury prevention, care, acute management, and rehabilitation for the football team. He previously gained experience as a graduate assistant athletic trainer with the Dallas Cowboys and the University of Alabama while earning his bachelor's and master's degrees. So we have two really wonderful people tonight. We're going to talk again about point of care ultrasound in sports medicine and featuring case reviews. Okay, so before we get started, I'd love to take a moment to go over some quick housekeeping. If you have a question, please go ahead and type it into the Q&A box. We're going to get to the questions live at the end of the presentation, but go ahead and put them in as we're getting through our presentation this evening. And CE is not available for this webinar tonight. And just so that everyone knows, you will all be getting a recording. This is being recorded, this presentation, and everyone who registered will be getting an email with the link to tonight's conversation over the coming week. Okay, Dr. Line and Louis, welcome and thank you for being with us tonight. I'm going to pass it over to you guys now.
Awesome. Thanks so much for the introduction. So we're going to go ahead and get started. You guys heard a little bit about my background. This is some of my training on the right side. I do hold a role, kind of multiple hats at Texas A&M. One of the team doctors. I also work as a clinical associate professor, as well as the assistant program director for the primary care sports medicine fellowship here. So I get kind of a cool role of training our fellow and some of our family medicine residents here. Yeah, that's my background. I'll hand it over to Louis for the next.
Thank you, everybody, for being here. My name is Louis, as I've been introduced. I'm the head football athletic trainer at Texas A&M, and I'm very fortunate to work with a great staff of athletic trainers and a wonderful team of team physicians. And that's going to be kind of the topic of our conversation today, is talking about how we work together and using point of care ultrasound to better serve our athletes.
Awesome. So our learning objectives tonight, really what we're going to do is review the use of ultrasound and point of care ultrasound in sports medicine, and specifically in the athletic training room setting. So here's kind of our four main points and kind of our roadmap for the presentation today. We're going to utilize ultrasound. How do we use that in the athletic training room setting? Review the characteristics of musculoskeletal ultrasound findings. We're going to go through some case reviews, both upper extremity, lower extremity, and real Division I athletes, and then going to go through a few procedural applications of diagnostic ultrasound in sports medicine. So first things first, just to kind of introduce you to, if you're not aware of what's out there as far as ultrasound goes, and really think about the resources that would be available to you. Depends really what your needs are. And so if you're a larger institution, if you're an academic setting, if you're in collegiate athletics or a research-rich setting, then a larger stationary unit or a laptop style unit may be what you're looking for kind of long-term as far as the power that you can have with an ultrasound. The example on the right is one of the types of ultrasounds that we have in our training rooms at Texas A&M. And so they're pretty high-powered machines that allow us to do a lot of different diagnostics. If you're in more of a lower resource setting, or if you need kind of more mobile or handheld options, there are plenty of options and utilizations for that as well. High school setting, mission trips, smaller clinical settings, lots of different opportunities to use a more mobile device in that style. There's also some laptop styles that are pretty amenable to portability, especially if you're going to set it up into different stations and then move it from there. So handheld ultrasound wise, this is a common question that I will get from our sports medicine fellows when they're thinking about getting a new ultrasound, or some people that will ask me just about my sports medicine perspective for handheld ultrasounds. There's a really good article put out by the Journal of Ultrasound in 2022, which essentially highlights what are the most common ones kind of available for purchase. And this doesn't have anything to do with Henry Schein. This is mostly just looking at saying, hey, look, this is a recent article, and this is what a group of 24 experts basically came together and gave their feedback on some of the most popular models that were out there. So this kind of covers, there's the Butterfly IQ, there's the Cosmos, Vscan, Lumify. There's a bunch of different options out there. Truth be told, I have a Butterfly IQ. That's the one I've used and trained with, and you'll see that it's usually the worst one as far as all these demographics go. But that being said, it's really helpful, and I've used it in multiple settings, and just to have the power of the ultrasound is a really cool tool to be able to help you with your diagnostics. And I do travel with that one as well when I cover A&M athletics. So as far as overall ease and image quality and everything, that's kind of on the slide. Y'all are welcome to review that or check out the journal article itself. Terminology. So before we kind of get into the nitty-gritty detail of the cases, it's important to know what some of the terminology means here. Near field, I may be using or I'll kind of interchangeably use that with top of screen, or far field to the bottom of the screen. Attenuation essentially means that there's a decrease in intensity, power, amplitude with the sound waves as it's traveling. So basically, the deeper it is on the screen, sometimes how it will show up as far as the image acquisition will change. Gain is really adjusting the intensity. And so there's some examples of that at the bottom of the screen here. There is like a little dial on most laptop style or stationary units of ultrasound machines that will increase the contrast or the gain. Depth will go really as vertical distance. You can change the depth and kind of the spacing in between that. The echogenicity, this will probably be one of the most important words that we kind of talk about if you're not familiar with ultrasound terminology. Hyperechoic is going to basically mean the brighter sections. There's more reflection. Things like bone will reflect back very intensely, and then there'll be some shadows below it. Isoechoic, things like muscle and fat. That means that it's equal as far as its echogenicity or the brightness on the screen. Hypoechogenic, darker or less reflection, and then anechoic is going to be black. That's going to be things where the sound waves can't pass through things like such as the fluid. And so your kind of key is at the bottom right of the screen there to look at that as well. Anisotropy is basically a term that's used to when you were using tilt in an ultrasound and different angles of tendons and muscles, etc., that they may look different. And it's a very common thing, especially for newer users, to confuse anisotropy with muscular strains or tears. And really all you got to do is adjust the tilt of the ultrasound probe. So just kind of know that sometimes it really is just dependent on how you're holding the probe when you're actually acquiring the images. So kind of a few more things we'll touch on here before we jump to the cases. And when we're applying the terminology, what do these things tend to look like? Veins are going to look like anechoic compressible structures. Arteries are going to be anechoic and pulsatile, typically not quite as compressible, always depends on how hard you push. Fat is going to be more hypoechoic. It usually has some irregular hyperechoic lines within them. Muscle, tendon, and ligaments, and bones. Those are going to be the biggest ones that we're going to be looking at in the presentation today. Typically, you're going to have anywhere from hypoechoic, but separated with some septa for muscles with some kind of a fibular type pattern. Tendons get more linear and fibular, and it's typically a smaller structure, tends to be more hyperechoic. Ligaments, similar to tendons, they're much more compact, but they're very hyperechoic. Bone, you'll see, is very hyperechoic, and then the sound waves can't pass through there, so it's usually a very sharp white line when you see a bone. Nerves tend to show up as kind of classically termed like a starry night appearance or like a honeycomb appearance. Usually those are best seen, or that specific characteristic is seen in a transverse view.
So the next part of our presentation here is going to be case studies, and all of these come from Division I athletes. Obviously, we have modified and taken out, de-identified all the information there, protect their health information. But all of these are very representative of what we see on a day-to-day basis. Jumping right in here, the first one we're looking at is a junior women's basketball player who has a history of left knee ACL reconstruction, presented to the athletic training room with a swollen left knee, felt that some increased discomfort in the medial knee during practice, during some cutting. Normal evaluation performed by the athletic trainer didn't show necessarily any ligamentous laxity except what you'd expect in a post-ACL knee. Some weak positive meniscal signs, normal neuro exam, a little bit of limited range of motion, probably due to that swelling. Initial plan was to brace it, see how they did, follow up with physician if that did not go well. And that brings us to our next part here.
Okay, so reviewing what do just kind of the format of the slides, what we're going to do is we're going to go through the case, do the presentation, and then we'll try and give you some anatomy here. We'll do normal first and then go to abnormal just to try and give you some context. There's a diagram at the top here. What we're really doing is we're going into the sagittal or the long axis plane, looking right over the patella. And this is kind of a long view this would be like a very big probe, but this is typically more of a dynamic. Multiple images are required at the same time in the machine to give you this sort of view. But what we're going to be looking at here is identifying the quadricep tendon. Let's see if I can get my little pointer here so I can start showing y'all. So over here, looking at the quadricep tendon, you get the patella, which has that nice hyper-echoic line with just some shadows that kind of go underneath it. Femur down here at the bottom of the screen, quadricep tendon, patella tendon, and the tibia. Let's go to the next slide. So this is the case that we'll be looking at, kind of the same view and what we're looking at. The patella again is going to be seen. Let me pull up my marker. Patella is going to be seen up here on the left side of the screen. Quadriceps tendon is going to be running along the top, and then this very anechoic fluid region right here, where I've labeled effusion, is basically the suprapatellar joint recess, and this is where we're going to see fluid accumulate typically as an athlete sustains an internal injury to their knee. Of note on this specific image, there was also some soft tissue swelling that occurred. This can often happen with a blunt trauma. As far as things to be aware of. It's not always just inside the joint. You also have some soft tissue swelling around it. As far as this 21-year-old, women's basketball player with knee pain, what her point-of-care ultrasound showed was mild knee effusion initially, and then it started to progress a little bit more. She had MCL and LCL fibers that were not disrupted on her evaluation, and you can do that with ultrasound as well. Sometimes it gets a little complex if you don't have the dynamic views going on there, as far as a static picture like we're looking at in the presentation today. The quadricep patella tendon, everything else, every other part of the joint assessment was normal. We did end up getting an MRI in her, which showed a knee tibial contusion, and she had some meniscal fraying. Her ACL reconstruction was indeed intact. The medial knee compartment with some post-surgical changes, but no new overt tearing. And so in her case, she kind of aggravated, that knee and her meniscus. She was fortunately able to do an initial period of Price protocol, compression, rehab exercises, some soft tissue modalities with cryotherapy. She was put on some nonsteroidal anti-inflammatories, given some activity modifications, and she was ultimately allowed to progress back to activity and responded well to conservative care.
Our next case here is a football player who came in with right posterior mid-thigh, some hamstring pain after a couple of days of fall camp. Did have no hamstring history, did have a significant quad strain in high school that he had dealt with, so kind of had a understanding of what an acute muscle strain felt like this might be something a little bit different. Evaluation of the hamstring kind of was similar to that. It didn't have necessarily anything that showed like he had an acute pop or pull or anything of that regard, but had some weakness with hip extension, a normal neuro exam. Anytime he activated his hamstrings or tried to do any kind of dynamic maneuver that elicited some pain. We kind of modified his reps, pulled him back a little bit. He tried to participate as best he could, handled it with typical athletic training room type treatments, some OTC medications, compression ice, a lot of modalities, a lot of Therex as well. At that point, something that, again, we're very fortunate to be able to do here is we can, we're not ultrasound techs. We're not going to do a formal ultrasound evaluation, but we're able to do more of a screening with diagnostic ultrasound. Our physicians have taught us that and given us the ability to do that. And so we're able to at least do a screening for any kind of significant defect.
All right, and so next kind of image here is going to be looking at the posterior thigh. So your kind of guide is on the left side of the screen here. We're going to be going into more of a short axis transverse view, and again, this is kind of more of a multiple image acquisition sort of picture and image quality that you're seeing here. But what my goal was with giving you this kind of normal picture is to show you how thick some of these muscles truly are in the posterior thigh, and then how that changes as you go down the leg. And muscle, if you kind of think of like a pork loin, this is what I describe to my patients when they're in the clinic setting. If you think of like a pork loin, then you cut a pork loin in half, that's pretty much what it's going to look like when you actually are looking at it on the ultrasound screen. So you do get some septations in the muscles themselves. On the screen here, the SM is going to stand for the semimembranosus, the ST for the semitendinosus, and then the BF there's a long head. It's kind of hidden in this picture, but that's the long head of the biceps femoris. And there's also going to be the short head in green in these pictures. So really what we're doing is we're just kind of going lower and lower and lower on the knee, scanning around. What we'll typically start with is a more of a sagittal or a long axis. I'll kind of scan all the way up and down the specific muscle fibers to try and identify if there's any obvious defect, just as Louis was mentioning. That's really what you're looking for the most part. Some of the subtleties and scar tissue can be challenging to see just because of the way the echo texture shows up within muscles. And you really go off of where the patient is reporting pain in these circumstances. So in this current example on the screen, medial is going to be reflecting that left side of the screen. So that's where more of the yellow and the light blue, the semimembranosus and the semitendinosus are present. And that's where those are very commonly injured as far as, athletes that have tight hamstrings and are doing explosive, sports and activities. So this one over here, this image is going to look at what a strain would look like if you pick it up on this. The same this actual images again from one of our ultrasound units. I was looking through images for this presentation, and I swear I don't know how many Louis and the other athletic trainers are doing, but man, we must have the entire football team's hamstrings scanned to some extent on our ultrasound machine. But this is a pretty good example of what kind of a more subtle strain can look like, but really just focusing on where the patient is telling you that they have some discomfort. And so I did some labeling here to show you where we're at. The yellow kind of marker on the bottom of the image in the middle of the screen is going to be your long axis. And so the fibers for this one, let me get my pointer back here. The fibers for this one are going to be going more longitudinal, nice and linear, but then you get up to the actual disrupted surface through here, and I just label it strain, but the reality is that is you're starting to get some echogenic disruption of the normal fibrillation pattern of the fibers. And so that's really what you're looking for. And then if you take this image and then cut it in half, this is what it's going to look like, is you get more of that intersubstance strain pattern within the semitendinosus itself. So this is very much what a hamstring strain will look like. And again, correlate that with what your patient is telling you as far as the physical exam, and then also where their point of maximal tenderness is. That's typically where I will start my exam. So the follow-up for this player, this 18-year-old football player, right posterior mid-thigh pain, his POCUS showed that he had performed initially by the AT, showed some mixed echogenicity, disruption of the fibers of the semimembranous muscle belly, consistent with a hamstring strain. They were referred over to the physician for that formal diagnostic ultrasound, which confirmed it. And then the treatment essentially, it's going to be very similar for most of these cases, but price protocol, compression, rehab, soft tissue modalities, dry needling is something that all of our trainers are very adept at, and is very helpful in the rehab of both acute and subacute injuries in our setting, and then cryotherapy. MD and DO kind of evaluation for this specific case, especially for the ones that get to be a little bit more extensive. We will do some either PRP or a brand called ACP injections, perform that to aid in the strain healing. There's some pretty good evidence that that's helpful as far as hamstring strain goes. After about 2 weeks, we'll start them on prescription anti-inflammatories or over-the-counter anti-inflammatories, and then we'll get them kind of aggressively rehabbed. And so that's the primary role where the ATs are really going to do the day-to-day work on that. Outcome for this one, limited activity for a couple weeks, and then essentially they advance back to full activity at the 4-week mark.
Looking at our next one is going to be a women's soccer player, 19-year-old with right anterior hip and groin pain. Was on defense, was taking free kicks on the defensive half of the field. Discomfort over the front of her hip. Felt like it pulled when she's in full hip extension. No direct trauma or fall there. Her muscle strength testing on exam was decreased with resisted hip flexion, mildly reduced in hip adduction, normal in hip abduction and extension. No bruising, no deformity there. Normal neuro exam, reproducible pain with lunges and squats, positive Fader testing, negative Faber testing, Ober, and straight leg raise test. Initial plan was some relative rest and some activity modification or volume modification. Did try cryotherapy after practices, started with OTC NSAIDs and some Tylenol for pain management. Started some therapeutic exercise with range of motion and conditioning program, and then referred to the physician for an athletic training room evaluation once she was unable to progress after 7 to 10 days.
Okay, so for this case, we're going to be looking at what a hip flexor and a hip flexor strain looks like. Very similar to hamstrings. What you're primarily focusing on here is the muscle, the tendon, and the musculotendinous junction. And so in this particular case, what you're doing again is we're looking at these long fibular patterns, and then also where the actual strain pattern is showing up here. And so this is the longitudinal view. The yellow is going to coordinate with the yellow on the image on the left of the screen. And really, that's going to be your longitudinal sagittal view that's going to try and get that full muscle fiber intact and shown here. And really what we're looking at this depth is going to be more of your hip flexor. And so when you have these findings, then of course go back into that short axis view again, you see some of the disruption of the normal pattern that we would expect to see here. Some of the mixed echogenicity, so you get some hyperechoic, some hypoechoic kind of patterns that are fixed together right over the hip flexor, confirming that with your palpatory exam, and that's ultimately how we're going to get our essential diagnosis for this, which is going to be the hip flexor strain. So for this young woman, a 19-year-old women's soccer player, right anterior hip pain, POCUS was performed, showed the mixed echogenicity, disruption of the fibers, specifically the iliopsoas musculotendinous junction, consistent with the hip flexor strain. So confirmed kind of what we were all thinking. It was the clinical diagnosis initially. The initial evaluation, price protocol, compression, rehab exercises, soft tissue modalities, dry needling again, cryotherapy. And then we ultimately discussed, the option for PRP injection. And, we give our student athletes the option. They don't have to do it if they don't want to. But they did elect to proceed with prescription NSAIDs. They were allowed to aggressively rehab with the athletic trainers and then did well with it afterwards. Activity modification, 3 weeks, and then they were essentially able to advance back to full activity at 4 to 5 weeks. That's fairly typical for a hip flexor strain when properly treated.
Our next one here is an interesting case, one that you certainly don't see every day. So we had a grad transfer football player who had a complaint of right calf pain, just did have a history, probably 7 to 8 weeks prior to this of an acute calf strain. At that point, had missed a week or two of activity and had otherwise been a full participant. So been full participant in all of workouts. Was an offensive lineman. At this point, not on any prescription medication, no history of clotting disorder or recent immobilization. Again, he had been a full participant in all activity. Muscle strength testing was normal. Again, big offensive lineman. He probably could not detect any subtle weakness at that point. Did have a little bit of, again, decreased strength in ankle, plantar flexion, dorsiflexion, eversion, inversion, all normal. A normal neurovascular exam, no visible skin changes. Did have some pain with calf squeeze. Felt like he might have kind of a full calf, if you will, but certainly didn't expect to see what we're about to see. His initial plan had been some kind of activity modifications, but really had been a full participant. Would do some generalized treatment after these workouts, and as we got closer to camp, then came in to honestly was looking just for some NSAIDs to help get through camp, and that's when he got seen by Dr. Line here and taken over from there.
So in this case here, we're going to start by looking at a normal kind of calf and sequence and what that would look like. Videos are very hard sometimes to get downloaded, so this is really kind of a static picture. Again, you have to use your imagination a little bit, but we did get kind of this panoramic view of what a calf is supposed to look like for you. In this view, you'll see that the gastroc is going to be overlying the soleus, it's going to be more superficial. We're looking at that same sort of muscular pattern. Remember my pork loin example that everybody always loves. You get those gastroc muscles over the top. That's mostly what we're thinking about when you think of calf muscles, and then the soleus muscle is going to be deep to that. The hyperechoic intramuscular septum that you kind of see in this top photo here, it's really going to just tell you, the separation between the muscles. And that's going to be important clinically for you when you end up evaluating deeper with the next image. So purple being the short axis kind of cut through the middle of the pork loin, and the long axis being at the bottom is kind of running long ways through it. So this was as Louis mentioned, this was kind of a surprise because this guy's calves were so enormous that we looked at it and go, holy smokes! How on earth could you have that much fluid in there? And it kind of immediately presumed it was a hematoma. The hypoechoic and not anechoic feature on here typically means that you've got some kind of stagnant blood or some clotting blood that's beginning to happen, and so. Essentially, what we did is, we kind of discussed it with the student athlete and said, okay, do you want us to try and drain this to get some pain relief here? And so this picture here is showing the needle kind of going into the athlete's hematoma, and then that's going into the actual spot. You see the needle tip that's indicated on the screen here as well, as long as the location with the gastroc and the soleus. And then that essentially all this fluid was then aspirated to look like this. This is the post-aspiration picture to be able to show you, where how significant truly there was in that, or how much fluid there was in that. I believe we ended up pulling out, correct me if I'm wrong, Louis, was 180 cc's out of this thing.
160, so that's 180. It was insane.
Yeah, it was syringe after syringe. It was one of those things where it's just like it's pretty incredible when you think about it. But got that drained. We did not put any medications into it the first time around, but he did have a subsequent aspiration, and then steroids were given at that point. So 23-year-old football player complained of right calf pain, found to have a large hematoma. The POCUS was consistent with that hypoechogenic fluid collection, defined intramuscular borders, consistent with a large hematoma. The aspiration was performed, got 180 cc's. MRI was subsequently performed just to see the extensive nature of this. And that ultimately showed some transverse aponeurotic disruption of the medial head of the gastroc. And the aponeurosis, kind of over with the myofascial, partial thickness myofascial tearing involved in the medial gastroc muscle as well. Treatment-wise, again, similar to the other cases, compression sleeve. This one was really, really emphasized in this case. Soft tissue modalities. This is not one that we tend to do dry needling, obviously, and this is going to be more so compression, soft tissue treatments, cryotherapy, and really just trying to get this hematoma to calm down. The repeat aspiration yielded at 80 cc's, got a steroid injection at that time. This was actually happened about 2 days later, reaccumulated pretty quickly, which is honestly to be expected in this circumstance. Case was discussed with some of our orthopedic surgeon colleagues, and then he was ultimately referred for a hematoma evacuation after discussing the risks, benefits, and alternatives to doing that. Ultimately, he was allowed to begin limited activities 3 weeks after post-op, and activity is tolerated back to live gameplay around the 6-week time frame.
Our next one, moving here to the upper extremity, a 20-year-old junior softball right-handed pitcher reported some worsening shoulder pain to athletic training staff as her pitch count was increasing. Also reported a fall onto her right shoulder while on a party boat the week prior. So every now and then, and more often than you'd probably think, we have some non-athletic related injuries that us or our team physicians are called upon to see, as they might impact their athletic participation. Athletic trainer evaluation had a positive Hawkins and near and empty can test, mildly reduced range of motion and abduction and flexion, negative labral signs, and was definitely neurovascularly intact. Typical, our initial plan here, relative rest, restricted from throwing and overhead weights, an activity modification, if you will, and started on OTC NSAIDs. And then got him with our team physicians, but again, when didn't really respond to those treatments.
So shoulder ultrasound is one of those things that is very complicated, and you very much learn from whoever ends up teaching you this. It's a There's multiple positions, and so I tried to put the position that we're kind of acquiring this position to, because sometimes that's helpful just in understanding where things are. This is an example of my medical assistant in my clinic was kind enough to loan her shoulder to this presentation so that I could give you some examples of some normal here. So going through and looking at this, really what you're trying to do is you're trying to identify some of the components of the rotator cuff and also the more superficial musculature. And so what we'll do with this one, let me show you my little cursor again here. So kind of focusing right here at the top, palm facing up and the arm externally rotated. I'm able to see some of that subscapular muscle. This is going to be the anterior view. Again, if we're connecting yellow to yellow, this is going to be that short axis plane over the front of the shoulder, anterior aspect. This structure right here is going to be the head of the humerus, and that's why you get that very hyperechoic line. You get the more hypoechogenic features above, typical of musculature, and then this is going to be the tendon, so more hyperechoic than the musculature up here. It's going to be more of a sharper white when it comes across your image acquisition. You want to make sure you try and see all these fibers get to the head of the humerus so you can see where the actual tendon is attaching. Also in the palm up, but more in a neutral position in the front without external rotation or internal rotation, you're going to try and see that subscap again, but then you're also going to see the biceps tendon sitting in the bicipital groove of the anterior shoulder. That biceps tendon will then run in and dive down deep into the labrum. You'll eventually lose it kind of going when it goes up more superior to the shoulder. Bottom right picture over here is looking at palm up, neutral position again. We're looking at that biceps tendon in a long axis view to be able to give us, firm evidence that that biceps tendon is indeed intact and that all those fibers are going together like we would anticipate them to. Next slide over here, really what this one is looking at is more normal pictures. When we look at these pictures over here, the deltoid is going to be the most superficial musculature. You get all the subcutaneous and fat tissue up top. Looking at this big picture first, this is going to be the infraspinatus. So this is looking on the back, kind of focusing beneath where the spine of the scapula is and going in that short axis view, trying to get where this supraspinatus or infraspinatus tendon is going to go over and attach onto that humeral head. Once again, then you get the deltoid. Then you also get the humeral head. This is kind of that posterior view as well. You get a little bit of that labrum in there, and then the glenoid as far as where things are attaching. Top right picture over here, you're going to see just a little snippet of the acromion process there. It's one of the bones. It's a good marker for when you're trying to see where the supraspinatus tendon is. This tendon is then going to roll over to the right and attach on the humeral head, very similar to that first picture we looked at with the subscapularis. This is going to be that long axis, and you're going to have your hand on your hip for this one just to optimize where that tendon is located. Hand on the hip again, short axis, looking through this deltoid. This is going to be the short axis, or the cut through the middle of your favorite pork loin, going through and trying to see that the texture and the intrasubstance texture of that supraspinatus is indeed intact all the way through. Shoulder bursitis. I took this one as an image. The student athlete we were having here, I didn't actually have an ultrasound picture of, but you can certainly use that to help you detect a bursitis. And this is one of the examples of what that would look like. Deltoid muscle at the top, subacromial bursa is going to be this hypoechoic or darker appearance that's going to be underneath where you see some of the other structures here. Get the supraspinatus tendon and then the greater tuberosity of that humeral head. Atop. So really what you're looking for are where these white arrows are pointing. Again, as Louis mentioned, sometimes you'll get these, non-athletic injuries that will then contribute to this. Was this a part of throwing technique, or was this actually, a result from one of her foosh injury or her fall, while she was on a party boat? Another thing, just to give you an example of what a rotator cuff tear will look like in this circumstance, because that's very clinically relevant. And sometimes you'll see this and it'll be chronic and not necessarily, quite as acute. But at the top picture here, what we're going to be looking at is the there's a supraspinatus tendon coming over, attaching that greater tuberosity and humeral head. You see this disruption, just this more hypoechogenic or darker feature where you're normally expecting to see more of a hyperechoic fibrillation pattern consistent with a tendon. So that's where you get, this is more of the articular sided partial tear. That's pretty consistent with what that looks like. A joint effusion, this is kind of more of a small joint effusion, this bottom picture. But really what you're starting to see is some hypoechoic or sometimes even anechoic fluid that's starting to kind of creep into and past the glenoid on that posterior shoulder exam with the ultrasound. And so that tends to be what that looks like. Oftentimes, the really bad glenohumeral joint effusions that we see in clinic, those are ones that you're going to have effusion kind of all over that back. And so sometimes it's hard to kind of fully distinguish, but it's just a big shoulder effusion. So kind of conclusion of this case 5, 20-year-old softball, right-handed pitcher, positive impingement and rotator cuff exam signs. POCUS showed that she had some regions of hypoechogenic and hyperechoic wall above the supraspinatus. No glenohumeral joint swelling, no evidence for rotator cuff tear. Those other two were just examples. And then the AC joint separation, no AC joint separation or bony abnormality. MRI was performed consistent with the ultrasound and showed that she did have a type 2 acromion process, which is very typical for impingement and kind of increasing your risk for subacromial bursitis symptoms. Treatment-wise, soft tissue modalities, cryotherapy. She was given a subacromial steroid injection, gave her some Dex, and then she was given some NSAIDs to follow that up and some Tylenol. Outcome was advanced back to activity as tolerated. She eventually made it back to live gameplay after 2 weeks, slowly waning up to that point.
Our next case here, looking at an elbow. It's a baseball player who's a graduate transfer, worsening elbow pain. Doesn't remember any specific mechanism or any specific injury. Has had several episodes of elbow pain over the last 6 months. Did have a positive valgus stress test with positive milking maneuver. Was positive for pain with pronation and supination and painful to palpation over the medial elbow and epicondyle. He was held from throwing. An appointment was made pretty quickly there with the physician in the athletic training room, who started him on a steroid pack and after just discussing this on the phone, and then saw him there pretty quickly thereafter.
So this case is really looking, at a UCL. What everybody's this is very much a hot topic in sports medicine is UCL evaluation and use of orthobiologics and ultrasound dynamic maneuvers. But this is nice because this is a structure that is usually pretty well seen on ultrasound exam, and it has a very good dynamic test where you basically just are applying a stress to that UCL to see if you can indeed gap it. These pictures over here, this shows you what a normal UCL would look like, kind of features the coronoid process, medial epicondyle, and UCL. That's all kind of labeled on the screen there with those arrows at the top of the screen, really defining the border, the superior border of the UCL. The diagram over to the top right of the screen is going to show you, more so what those bone-to-bone connections, the ligaments of the UCL, where those are it's kind of more of a broad ligament, kind of has some multiple components to it. And then also associated with UCL tears is flexor pronator mass strains and inflammation and discomfort. And so on clinical exam, if I teach my fellow that if you if you're doing a UCL test and somebody's complaining of medial forearm pain and you're palpating over the flexor kind of proximal flexor muscles of the forearm, then definitely need to have a high index of suspicion to evaluate for that UCL as well, because it's very much going to be correlated when you get those injuries to also have a flexor pronator muscle injury. UCL tears. So what does that look like? This is a pretty characteristic example of running through the middle of where you would expect to see those nice linear fibers of a ligament. So again, those are going to kind of typically be more compact, hyperechogenic fibers that show up on ultrasound. In this specific image, it's showing up as a little bit more hypoechogenic, but you do see kind of a very clear disruption through the middle of the fibers there. And then the flexor pronator mass is going to be immediately above it. So to summarize this case, 23-year-old graduate transfer baseball player, left-handed pitcher, worsening elbow pain and instability. POCUS showed a disruption of the normal fibular pattern of the UCL, have some hypoechogenic features under the UCL, consistent with swelling. Mixed hyperechogenicity at the flexor pronator mass, medial elbow, epicondyle, dynamic maneuvers showed increasing gapping with the valgus stress test in this case. MRI was performed. It ended up showing a full thickness UCL sprain, and then they were ultimately referred to orthopedic surgery for consultation and had a UCL reconstruction surgery. In the meantime, before surgery, the typical soft tissue modalities, cryotherapy, compression sleeve, etc. They were held from activity up until that point. They were able to successfully return to play to collegiate athletics after surgery. Takes a while for these ones. It's basically the ACL of the elbow, and so it's going to take some time. This person was able to make it back to play in about 10 months.
Looking ahead there to our next one here, this is one we'll get a chance to see more of a procedure type base. So we have a 20-year-old football player with low back pain presented to the athletic training room. No specific hit, tackle, any kind of mechanism, just kind of intermittent radicular pain down his right lower extremity. At that point, he had no history of back injury or any kind of medical illness, had no saddle anesthesia or bowel bladder issues, no fevers. Did have a positive straight leg raise test on the right, weekly positive Fader and Faber testing, positive Trendelenburg testing on the right, limited active range of motion in the right hip with flexion and abduction. Muscle strength testing was noticeably weak in flexion and abduction, and remainder of manual muscle testing was negative. He was intact bilaterally, lower extremity throughout, with in terms of sensation. His initial plan, we've got him evaluated by a physician and started on a muscle relaxer and a Medrol dose pack for back strain and lumbosacral radiculopathy, and did get an MRI there pretty quickly.
So this is a good example for, you don't necessarily jump to ultrasound immediately. You kind of get them to over to, get an MRI to evaluate for disc bulge and their lumbosacral radicular symptoms. But this is one of the treatment options that we're able to provide using the ultrasound as a tool. And so on this structure, I kind of highlighted in the purple here, that's the border of the bones that we're looking at, aka the sacrum and the PSIS. And really what we're doing here is you're kind of getting deep towards the lumbar multifidi, kind of right next to the sacrum in between the PSIS, and you can try and get to that SI joint. It's quite difficult to do sometimes just using ultrasound guidance, but you can get the medicine pretty close, the steroids pretty close to where that sacroiliac joint is, and then you're also getting it to kind of do like a deep trigger point injection where that lumbar multifidi is. And so this can provide a lot of relief because very often, these symptoms are, disc bulging, or whether they are nerve impingement symptoms that are kind of leaving the L5 space. Putting concentrated doses of steroids around the vicinity can be quite helpful as far as reducing symptoms. And so this is one of those cases where, whether it's true sacroiliitis or more lumbosacral radiculopathy, that you can actually do an ultrasound guided procedure, palpating the PSIS border, putting the ultrasound probe over it, and then guiding the needle as close as you can, basically over to the kind of that sidewall of the PSIS, to be able to then administer some steroid and some local anesthetic. So recap here, 20-year-old football player, low back pain, right-sided radicular features, did a sacroiliac joint injection, paraspinal muscle trigger point injection on them. MRI did show a disc desiccation, height loss, along with some mild broad-based disc bulging, leading to like some stenosis to the right lateral recess, affecting the S1 nerve root. So treatments were provided, dry needling, cryotherapy. They got some formal PT referred. They tolerated the injection really well, and they were actually able to advance back with just that. Sometimes they'll need some more targeted injections, transforaminal epidural steroid injections or facet joint injections. But so that option is usually laid out before them, and then they can use it if they need to, if they're not progressing with an SI joint injection. This student athlete was able to successfully return to play around the 6-week mark. Other procedural applications, just to kind of let you know about what else is available, and then we'll start some questions, is the ultrasound guided joint injections really can be any joint. And so whether that's a small joint, intermediate joint, or a large joint, that's things to think about. There's really no place you can't reach with a well-placed needle in this circumstance: shoulder, knee, hip, etc. Carpal tunnel injections, not technically a joint, but also getting good procedural application there. Not quite as common in collegiate athletics, but certainly is still utilized in management of of athletes of all ages. Compartment syndrome testing, you can use that to augment your landmark identifications and make sure you're getting into the appropriate position and location when you're doing that. For the assessment of chronic exertional compartment syndrome. Plantar fascia injections, that's quite a painful one, but sometimes if you use an ultrasound, you can really assist in making this injection the least painful as possible, just because you can really avoid a lot of sensitive nerves in the pad of your foot. Ultrasound guided injections to musculotendinous injuries, as we've discussed, using PRP, orthobiologics, etc. Lots of different ways you can use ultrasound as a diagnostic and therapeutic tool. And that is what we have. So at this time, I think we'll open it up for questions.
Thank you so much. That was incredible. Really wonderful insight. Very edifying. And yes, now we open it up to questions. Please go ahead and type your comments and thoughts and questions in the Q&A box at the bottom of your screen, and we will be reading them live to Dr. Line and to Louis. Just while we wait, are there any frequently asked questions that you, Dr. Louis, Dr. Line or Louis get, either by your players, I guess mostly by your players when they're seeking treatment or when they're trying to figure out what they have? What commonly asked questions do you guys often see?
One that we see quite a bit of is the desire for follow-up, wanting to see, what does the muscle look like after it's been injured and how long does it take to go back to looking more normal? We know that can take quite a bit longer than what their function and pain would dictate. And so, what we always tell them is we're going to treat the patient, not the test. And so we are going to take them through a comprehensive rehabilitation program. And if objectively speaking, you have passed all of the tests we're looking at and you've regained all of your function, you've regained range of motion, your strength, you're pain-free, you're hitting your top speeds again, we know that hamstring is clinically healed. And so the image on the screen might not be as important. We know that as professionals, we know that could take quite a bit longer to catch up on the screen and it might not ever look the same. And so that takes a lot of education on to educate the patient so they're not misunderstanding and not too worried about what they're seeing on the screen and misrepresenting that as being something where they're not healed yet.
Oh, fascinating. And we do have a couple questions that have come in. We've got one here from Dr. Catherine Berry Hill. What indicates the use of a PRP injection?
Yeah, so good question. And the reality is that there's still a lot of medical literature that's working on trying to give more straightforward indications for these. I'll tell you that in the use in the collegiate training room and also in my private orthopedic sports medicine practice that I'm in, you're typically doing that because you're trying to fix or repair something and give them a non-surgical option to do so. The most common reason we would use it in an athletic training room setting or in our younger athletes is going to be either ACP, which is a product by Arthrex, and it's kind of a platelet, like a whole plasma type injection, compared to something that is truly more like a PRP, platelet-rich plasma, whether that's leukocyte-rich or leukocyte-poor, that will then there's a variety of protocols, and really the research is trying to get to more defined criteria for when to use that. But the most common reasons to do it: hamstring strains, quad strains. There's lots of evidence, I should say growing evidence for use in partial rotator cuff tears, partial UCL sprains. So a lot of the topics we discussed in this lecture, are ended up using various types of orthobiologics. I do not use prolotherapy, bone marrow aspiration, or any of the other stem cells in my own personal practice, but there are many practices out there that are doing that, and research is still kind of growing. And long story short, the verdict is kind of still out to see, how much of that stuff, whether you're for it or against it, is going to be condoned by the sports medicine communities, whether that's ACSM or the AMSSM, kind of at large. These are always very hot topics at our national conferences.
So true. This next question is from Dr. Imperial. How do you differentiate acute from chronic changes on the US?
Yeah, so good question. So acute versus chronic changes on an ultrasound. A good example would be something like, let's just take a quad strain. Acute quad strain, you're going to see, typically you're going to connect this with your history, your physical exam, et cetera. And so kind of like Louis was saying, ultrasound is a tool. You use it kind of like you do your stethoscope. It gives you more information, then you apply that back to the patient. So, in an athletic setting, you have somebody that comes in, they've been complaining of anterior thigh pain. You ultrasound them and you see that, you have some kind of subtle changes there. It can be difficult to say, did this happen, today, or did this happen 2 weeks ago? Sometimes that's hypoechogenic feature can stick around longer. Things that are more indicative of a recent injury would be things like that calf hematoma that we were talking about. That one seems pretty fresh. That would have been basically in about 2 weeks, you get more fluid collection. But typically, if you have a really, like a new joint effusion, then that will collect pretty quickly. And if there's blood in it, then it won't fully clot yet. So there's kind of a few different clinical features you can see. Long term, if you're looking at large muscles, very bright hyperechoic structures typically is what in the fibrillar pattern is what a scar tissue is going to look like, and that can indicate more of a chronic change. When you get into things like rotator cuff tears, you look for similar patterns. Somebody can have a long-term partial rotator cuff tear, but they don't necessarily have pain there, and so you can use the ultrasonic probe and do a compression test to see if that actually is causing them pain at that area too.
Thank you for that, Doctor. And this next question from Dr. John Vivolo: thoughts on intramuscular corticosteroid injection for strain versus platelet poor or platelet rich plasma?
So the kind of in general, like use of steroids versus platelet poor or whatever PRP you decide to use, really it depends on time frame. And so that's a great question for the use in sports and athletics here, is because I can give somebody an intramuscular injection, and then they can go out and they can try to advance their activity in that same day or the next day. Now, naturally, it depends on the specific pathology you're looking at, but typically if it's going to be something you're injecting PRP into, really the goal is you want to try and shut them down, that activity, and get them to do more of the rehab, so that you can actually get the PRP to do that healing process, which can take several weeks, to be perfectly honest. Serial ultrasounds is helpful to kind of gauge, how quickly, those things can heal. I'll tell you that usually intramuscular injection into, like an acute strain, it can be helpful short term, but long term, it may not have the largest benefit for helping that heal. It may help it scar down faster sometimes, but again, it's kind of a point of contention, and you'll get different stories from different docs when you ask them.
Interesting. And this next question from Dr. Shane Clark: how much can the ultrasound help in diagnosis and compartment syndrome, especially those images of the gastric area showing an effusion?
Yeah, so exertional compartment syndrome, typically what we're doing as far as the assessment in that is going to be using some sort of compartment pressure device. And so what I'll use is just to kind of help augment the landmarks. I'm honestly not familiar if, you're actually doing measurements of each of the 4 quadrants, in the leg, the compartments of the leg, to, if there's any validated or standardized sizing. I imagine that would be hard to do just based off of patients, body habitus and, and variability on that front. But usually you're going based off of the pressure testing, and the ultrasound is mostly going to help guide you to the right quadrant. We'll use that. I basically use it to mark, and then I'm doing landmark based just when I know I have the right needle trajectory when I'm doing that for my CECS evaluations.
Thank you. And this next question from Dr. Robert Fleigelman: how does an ultrasound separate chronic changes from previous injury to the same muscle ligament or tendon?
So chronic, interesting question. I'll do my best to answer it. Sorry if I'm missing some of the components of your questions. I'm trying to get as best I can. Ultrasound, as far as like a chronic, let's say you have a chronic tear next to a more acute tear. Again, what you're going to kind of see from more of a chronic type finding in these sorts of tissues is more of a hyperechoic scar type tissue. Sometimes you really may not see anything. If you get your run-of-the-mill hamstring strain and there's really no effusion that kind of is resultant, or no hematoma or fluid collection, et cetera, then you might really not see anything on repeat ultrasound in about 4 to 6 weeks. Those very typically will be hard to find. Louis can tell you that, when they're going through and looking at hamstrings and quads in the training room, half the times you don't see anything. The muscle looks normal, but at the same time, symptomatically, they're presenting like they have a strain. And so they're still treated as a strain. They just don't have a really gross tear to make you kind of go that extra level to say, okay, well, are we going to consider doing an intramuscular steroid injection? Or are we going to do more of a PRP or an orthobiologic? And so that's hopefully going to help answer some of that. But again, kind of chronic scar type tissue is typically going to be more so hyperechoic, following that same fibrillation pattern, and typically where their injury site was. And then the newer strain patterns are going to be more hypoechoic, following the fibrillation pattern. But then, point of area of maximal tenderness can be hard to differentiate between if it's chronic or acute.
Thank you. And this question from Dr. Garcia Rhodes Jr. What are both of your strategies for incorporating and maintaining use of ultrasound in the athletic training room?
Yeah, well, I can hop on here finally there, Doc. Let me take one for you.
Please
give me
do.
a break. Yeah, so, first and foremost, again, I just got to say we're very fortunate here. We have great resources, and we have an administration that is really helpful to us and allows us to go out and get these types of things. I think it's important to show its value in the era that we're in. There's a constant desire from the patient population that we're seeing for advanced imaging. And so rather than spending anywhere from $600 to $800 on an MRI, even with the discounted rate, where you can take them back to our diagnostic imaging room that we have here and do an ultrasound for free. Obviously the machine wasn't free, but each test is then free to us. And so that in and of itself can give the athlete some peace of mind, while obviously giving us the ability to get an accurate diagnosis and to get an accurate picture, and to do so in a dynamic way. An MRI is fantastic and can do some great things, but it's going to give you a static picture. Whereas you can take somebody, we've had some tricky hamstrings over the years, and they only will feel it when they're doing certain movements, and it might otherwise look normal, but you can take them through some active, knee flexion extension and have that probe on it. And then you can probably detect an area in that muscle fiber that you might not have otherwise seen on an MRI because it's static. And so being able to show its value to whoever the decision makers are, whether that be administration or head of department or whoever that may be, is obviously the key to incorporating it. And then maintaining its use is obviously we got to use it, right? The machine is fantastic. And the one that we have here at our athletic training room is certainly one that is probably considered closer to top of the line, but it would do us no good if it sat there all day and didn't get used. And so, as Dr. Line pointed out, going through all the different pictures that we have, we use it very regularly. We're able to use it even for treatment, talking about dry needling. We can do some very targeted needle application with the ultrasound probe, with the ultrasound head, and make sure we're going right into the area we're trying to hit. We feel like there's an area of some scar tissue buildup, some scarring, that we might be able to treat really effectively with some dry needling therapy. Now we can do so with that ultrasound probe and hitting in the exact area. And so to maintain the use of it, to answer that question, is just using it. Make sure we're using it. Make sure that we're justifying its use by not letting it just sit there all day, every day.
Yeah, and I kind of mentioned earlier that, the ultrasound is being used more and more like a tool, like a stethoscope, which is, most medical students, are starting to get from training very early on. Lots of different ventures are trying to, increase this knowledge base so that, this isn't quite as foreign of a concept. But really, ultrasound is in the power of the user. And so you have to be familiar with it. You have to know about all that stuff. You got to get the right training for it. And training is usually the hardest part. If you have a medical degree, then you can get any of the ultrasounds we kind of talked about, and you can start tinkering around and playing with it. And realistically, there's lots of great informational videos on YouTube. AMSSM, European societies have different handouts you can look at. And so, it takes a lot of time to go through it. I'll tell you that when it actually comes to my clinical application, I'm using it as a tool. Most of the times I'm not really creating huge diagnostic reports unless that's specifically what I'm being asked to do. But the use of ultrasound to guide procedures, to use that as far as your clinical practice setting, can really help augment your billing. That can go up if you're thinking about RVUs and CPT codes, and ultimate reimbursement for your smaller practice, your group practice, and trying to say, hey, is an ultrasound something that I can get my clinic to buy for me? It will pay off. It just takes time and use to be able to get that going. So. It's a great tool, to be able to then show your patient. I use this all the time. Even if I already know the patient has a knee effusion, I'll ultrasound them, and then I will show them, on the ultrasound saying, hey, look, you're not supposed to have all this black stuff on the screen. That's fluid in your knee. We need to get an MRI of your knee to really firm down and pin down what you got going on. So training room, very similar, you got to use it if you have it. But if you're in the high school setting, if you've got a portable one, great application to use it, to be able to look at hamstrings, quads, looking for knee effusions. You can use this on the sideline in a high school football game on a Friday night, or you can use it in the tent at a NCAA Division I, football game where there's people screaming everywhere, 100,000 people. So it's been a pleasure to do this presentation. Thank you all so much for having us. And sorry for droning on my monologues, but hopefully it was helpful for y'all. We're grateful to be able to do this.
That was just fascinating. Thank you so much, Dr. Line, and thank you so much, Louis. Really interesting to learn about the innovative ways that ultrasounds can help patients and the world beyond and patients beyond. We did record tonight's webinar, and we will be emailing the recording out sometime in the next week. Thank you again all for joining us and for joining Dr. Line and Louis for this wonderful presentation. We would appreciate your feedback via our survey that will pop up on your screen shortly. Thank you again for this wonderful evening, and we look forward to seeing you on future webinars. Thank you.
Yes.
Good night.